Okay, my name is Jen Suresh. I'm the Director of Operations at the Brain Injury Alliance of New Jersey. I want to take a moment and thank you for joining us and being a part of our annual seminar. Before we get started, I'd like to remind everyone to enter your full name in the chat. This is our virtual sign-in sheet. If you are going to request CEUs, remember that you must attend this workshop in its entirety, complete the workshop evaluation, and if required by your discipline, complete a post-test. I will be entering that link in the chat for your convenience. Zoom will provide a report of how long each of you stayed in the workshop. CEUs cannot be given if attendance is not verified. Questions are encouraged. Please enter questions in the chat and they will be addressed at the end of the presentation. This workshop is Journey of an Acquired Brain Injury Due to Opioid Overdose, an Acute to Subacute Rehabilitation Perspective. And our presenters are Dr. Brian Greenwald and Ms. Tara Lopez. Dr. Brian Greenwald is the Medical Director of Center for Brain Injuries and the Associate Medical Director of JFK Johnson Rehabilitation Institute. He is the Fellowship Director for JFK Johnson's Accreditation Council for Graduate Medical Education, Certified Brain Injury Medicine Fellowship. Additionally, Dr. Greenwald is a clinical associate professor, and he just told us as of July 1st, a full clinical professor, so congratulations to you, in the Department of Physical Medicine and Rehabilitation at Rutgers Robert Wood Johnson Medical School, and is a core associate professor in the Department of Physical Medicine and Rehabilitation at the Hackensack Meridian School of Medicine. Dr. Greenwald completed his residency training in the Department of Physical Medicine and Rehabilitation at Rutgers, New Jersey Medical School. He was fellowship trained in brain injury rehabilitation at Virginia Commonwealth University. He is board certified in physical medicine and rehabilitation and brain injury medicine. Dr. Greenwald is the medical director for JFK Johnson Traumatic Brain Injury Model Systems Research Grant, which is funded by the National Institute on Disability, Independent Living, and Rehabilitation Research. Dr. Greenwald has served on the Board of Trustees for the Brain Injury Alliance of New Jersey since 2002 and is currently the vice president. Dr. Greenwald has been the recipient of multiple awards for his clinical work, research, and teaching. Since 2009, he is recognized by his peers through the Castle-Connolly surveys as one of the top doctors in the New York metro area. Dr. Greenwald has published multiple articles and book chapters in the areas of brain injury rehabilitation. Currently, he is involved in several research studies to improve the care of brain injury survivors. And thanks for joining us this morning, Dr. Greenwald. We also have Tara Lopez, MS, CCC, SLP. She has been a practicing speech language pathologist since 2016. She is currently practicing at Hackensack Meridian JFK Johnson Rehabilitation Institute on the brain trauma unit. Her clinical experiences include assessing and treating cognitive communicative disorders due to stroke and TBI in the acute, inpatient rehabilitation and subacute settings. She graduated cum laude from Loyola University, Maryland, and received her Master of Science in Speech Language Pathology at Teachers College, Columbia University in the city of New York. So welcome, Ms. Lopez. Thank you for joining us. And for those that joined late, before we get started, just a reminder to please put your name in the chat. That's just your record of attendance. And make sure if you have any questions, feel free to put them in the chat and they will be addressed later. And with that, I will turn the presentation over.
Well, thanks so much there, Jen. With all those fancy things that you got to say about me, really, this is Tara Lopez's talk. I appreciate Tara letting me give a little bit of the medical part in the beginning, but this is really more geared towards speech therapists and sort of the interesting story of this one patient, but in overall patients who go through anoxic brain injury are related to opioid overdose. So both Tara and I are currently full-time salaried employees of HMH JFK Johnson Rehabilitation Institute. That's our only disclosures. And so our objectives today. So today we're going to identify the pathophysiology and cognitive impairments resulting from an anoxic brain injury. We're going to cite barriers and limitations associated with hypoxic ischemic brain injury due to drug overdose. Tara is going to describe traditional and non-traditional strategies to target language and cognitive skills, and participants will be able to apply learned knowledge through a presented retrospective case study. So let's first start talking about opiates. So opiates are substances that bind opiate receptors in the central nervous systems, and they can be broken down into endogenous, like endorphins, like we talk about when we've gone for a good run or exercise, naturally occurring, like the opium from poppy seeds, semi-synthetic, like heroin, or synthetic compounds like methadone or fentanyl, and these trigger an analgesic effect. And obviously in medicine, when we think about it, we're trying to trigger someone who's in pain. We're trying to use it for the analgesic effect, but it also has a euphoric effect, which is part of the challenge and one of the reasons that it that becomes addictive and becomes abused. So I'm sure the people here online, I don't have to tell them that really the opiate epidemic has become a nationwide public health crisis. Certainly a significant increase in overdoses due to heroin and fentanyl versus the pharmaceutical opiates. And it's so much in the news over this last decade and so much in the news currently. Here, according to this study from 2020, when we look at July 2016 through September 2017, there was a 30% increase in opiate overdoses treated in the U.S. emergency rooms. Overdoses in large cities increased 54%, and approximately 70% increased in overdose treated in emergency departments. Just a tremendous number that's going on. So why do opiates cause overdose? Well, really, it relates to respiratory depression. So when we think about the biology of respiration, of breathing, respiration drive begins in the brainstem and is modified by inputs from the cortex, the central brainstem, and peripheral chemoreceptors in the carotid and the aortic bodies. The respiratory rhythm is most opiate sensitive aspect of respirations. So respiratory depression is related to two things. One is change in respiratory pattern, meaning how often you're actually breathing, and two is changes in the tidal volume, the amount that you're breathing. uh, Results and this respiratory depression results in denying oxygen to the brain, and the brain is so sensitive and is so oxygen dependent, and that leads to anoxia, a lack of oxygen, hypoxia, low oxygen, and hypercapnia, high carbon dioxide. Now, fortunately, there is a reversal agent, and then hopefully, when people do overdose, that they're able to get that reversal agent as quickly as possible. This, I think, is impressive when we look at EMS administration events of using naloxone. Let's see, between 2012 and 2016, a 75% increase in use of that. And that's in overall in suspected opiate overdoses, 119% increase. When we look at CDC opiate-involved death rate, a 79.7% increase over that period of time between 2012 and 2016. Like I said, this has really been such a huge issue over this last decade. So when we think about the brain itself, so the brain, like I was saying, is very sensitive to and is so dependent on oxygen, and oxygen being there all the time. It has no significant storage of oxygen that can go without oxygen. So in a hypoxic event where there's restricted oxygenation to the brain, or in an anoxic event where there's a total lack of oxygenation to the brain, if we have prolonged, limited, inadequate oxygenation to the brain, we're going to get brain injury. Some key factors as far as what is going to influence the brain injury is how long that low oxygen is going on, and then the areas of the brain that are most affected. And interestingly enough, the different areas of the brain are more or less sensitive to hypoxic injury. The whole brain is sensitive to it, but certain areas are more sensitive earlier than other areas. Certainly, the people's premorbid function. So, the person who is 20 and suffers an overdose or an anoxic brain injury versus the person who's 80, certainly those will have an effect on the outcomes. Unfortunately, cumulative damage can also occur with multiple instances of overdoses. So neuroimaging, so CAT scans, MRIs, often not so sensitive early on, similar to why they're not so sensitive after concussive injury, similarly because they're not so concussive. Even after severe brain injury early on, we may not see significant changes early on. It's not until later on as the brain continues to suffer injury or the brain cells continue to die that we see those changes. And when we look at some of the changes of studies of drug abusers, some of the things that we see are one, brain atrophy or a thinning of the brain tissue, focal demyelination. The myelin is the covering of the brain tissue itself or of the axons, and we could see demyelination or loss of that myelin tissue, hyperintense lesions, focal perfusion deficits, focal deficits of blood flow to certain areas, metabolic disturbances, changes in the metabolism of the brain, neurochemical abnormalities, structural abnormalities in the white matter, which is the telephone wires hooking up to different parts of the brain. And all this is just with CT scans in the study from 2018. So like I was saying, there are certain areas of the brain that we know that are particularly sensitive to this, and Tara is going to talk more specifics about these different areas and the functions of these areas. But one of the areas that we know that is most sensitive to anoxic or hypoxic ischemic injury is the hippocampus, and the hippocampus is so important for memory and learning. It is really the key element for short-term memory, and then short-term memory loss is one of the key things that we see in persons with anoxic brain injury, even for relatively short-term anoxic brain injury. The neocortex, the basal ganglia, and the cerebellum, all very important for movement. The brain stem, as we were talking about, can cause the person to die. The occipital or parietal cortex, which can lead injury to that area, can lead to cortical blindness. And then the thalamus. And if people who are on the last talk, who are on the initial talk for the day, he talked about how the thalamus really is the highway to consciousness. And unfortunately, people whose anoxic injury or hypoxic ischemic injury is severe enough that they have thalamic injury, unfortunately, those are the people who tend not to wake up. But again, the thalamus is very sensitive to this lack of oxygen. That's my beginning of the talk as far as talking about some of the medical aspects. I'm going to turn the talk over now to Tara, who's going to continue this talk. Let's see, now I just got to stop sharing so Tara can share.
Hi, everyone. Thank you, Dr. Greenwald, for getting us started. As listed in the previous slide, the frontal lobe is extremely susceptible for an hypoxic ischemic injury. One reason why is because of its widespread connectivity. The frontal lobe is interconnected with a relay system transmitting high-level auditory, somatosensory, and visual information in order to organize an individual's behavior by activating, inhibiting, and integrating ideomotor and sensomotor activity. When damage to the frontal lobe occurs, it can negatively impact a patient's ability to perform executive functioning skills and complete complex tasks. In addition, the frontal lobe has a huge role in an individual's personality, judgment, attention, and insight and awareness. Here I want to take a step back and analyze executive functioning that the frontal lobe is involved in and how it applies to functional real life. For example, here you can see how during a normal conversation, key executive functioning components are involved, such as when to initiate a conversation, appropriate turn taking, topic maintenance, generation of ideas, and awareness. Another example involves grocery shopping. You're hungry, but the fridge is empty. Do you initiate to fill it and go to the store and go shopping? Or an individual is impulsive and buys the first item that they see at the grocery store, or a bunch of items that are not needed. Or they're missing items on their list. And lastly, they might not be able to attend to the signs in the store to locate the items that they need. These are just some examples on how key functions of the frontal lobe are integrated into real life. So now that we've discussed how the brain and body loses oxygen to acquire hypoxic ischemic brain injury due to opioids, we haven't discussed what happens next. Due to oxygen deprivation, a variety of impairments can occur, such as impaired language, dysphagia, mobility, and cognition. Looking at the area of language, an individual can present with receptive or expressive aphasia, motor speech disorders specific to dysarthria, apraxia of speech, or ataxia. Looking at dysphagia, an individual might require a modified diet or alternative means of hydration and nutrition. Cognitive impairments, such as poor memory, reasoning, problem solving, thought organization, attention, and poor insight and awareness. But lastly, we have mobility. An individual might present with increased tone, spasticity, and limb apraxia. These can all negatively impact a patient's ability to walk and perform self-care tasks. With this type of population, the severity of the level of impairments can vary significantly. For example, there can be some patients who are in or emerging from a minimally conscious state, or there are some patients in non-clinical terms we might call walkie-talkies, in which they appear okay to the physical eye, they're walking around the room, they look okay. However, when you ask them to count coins or perform a shower or dressing task, they can't, because they can't plan or coordinate how to perform these targeted actions. But keep in mind, these are also the type of patients that will tell you that they need to leave right now and you need to give them their keys because they need to drive home. One thing that also can result with this kind of population of a patient is emotional changes, such as an increase or decrease in instances of emotional ability. For example, an individual might be overly emotional and cry very easily, where they're experiencing difficulty or for no reason that they can identify. Or they can have the total opposite effect, where they have no emotions at all and are extremely flat. Another emotion that can occur is increased irritability. This can present as being short-tempered, have poor tolerance for structured tasks, yelling, attempting to hit, bite, or scream. For patients exhibiting significant agitation, sometimes therapy just involves increasing a patient's ability to tolerate your presence in the room. In addition, an individual can also exhibit increased impulsivity. All of these key elements can impact a patient's ability to perform during their therapy sessions. Similar to as I mentioned before in the previous slide, each individual presentation varies and severity varies as well. As stated before, I said an individual with hypoxic ischemic brain injury can present with language impairments. I want to break it down here and describe how that might present. Regarding expression, an individual might have difficulty expressing themselves, such as they can't name objects, describe things, or they have poor verbal initiation where they don't initiate to say something. Then there's the total opposite, where someone might be very verbose and tangential, where they start talking about one topic and they jump all over and don't stop talking. This is where you see the involvement of the frontal lobe and the impairments of cognition as well. Regarding receptive language, an individual might exhibit impaired ability to understand language or delayed processing of auditory information. An additional type of impairment includes motor speech disorders. It could present as dysarthria, it could present as apraxia of speech, ataxia speech, or voice disorders. All of these aspects can negatively impact a patient's ability to speak clearly, therefore making speaking very difficult and effortful. As you can see here, pragmatic deficits can include poor turn taking, eye contact, inappropriate topic selection, or commentary. The area of pragmatics is significantly impacted by the damage to the frontal lobe due to the impairments in executive functioning. Hence why you might see these types of impairments in the hypoxic ischemic brain injury population. As you can see here in the diagram, the patient's expressive language can be intact and within normal limits. However, they talk all over you and they exhibit pragmatic deficits due to their cognitive impairments and their inability to recognize what they're doing or regulate personal awareness. After sustaining this type of injury and exhibiting language, cognitive, or physical impairments, there can be a lot of stress and responsibility placed on family and or friends. This can potentially cause a disruption in family communication, decrease in social interaction, quality of social interaction, and decrease or inability for the patient to be independent in the community, at work, or school. Keep in mind, individuals who have this type of injury might have been the breadwinner of the family. They might be bringing in all of the income. Now families, stuck and they're trying to figure out what to do because their source of income is now changed. With the assistance of a strong support team, such as social workers, therapists, doctors, we try and provide assistance and education in order to assist with the expectations for home as well as discharge or the next level of care. As a speech language pathologist across the continuum of care, such as acute care, inpatient, and subacute settings, my role involves evaluating patients' language, cognitive, and swallowing abilities, developing a treatment plan and goals for their length of stay, educate the patient as well as their family regarding the patient's language and cognitive impairments, progress, and the use of compensatory strategies. On a daily basis, I collaborate with fellow medical professionals to address the needs of the patient. Medical professionals such as physical therapy, occupational therapy, social work, recreational therapy, behavioral health, and psychology. During a patient's stay, it's essential that an individual's physical needs are met, as well as their behavioral, emotional, and psychological. Here I've listed some of the formal assessments that we utilize to assess patients' language abilities. I'm not going to go into much detail about these, but I want to share some of the assessments we typically use. An additional assessment that I have listed below is the Coma Recovery Scale Revised. This is an assessment that was developed originally at JFK Medical Center, and it is a neurobehavioral assessment measure designed to assess the disorders of consciousness. It is also used to monitor rate of recovery and assess the treatment effectiveness. This is another treatment assessment that we utilize pretty frequently. Here I've listed some formal assessments that I currently utilize to assess patients' cognitive linguistic abilities. I'm not going to go into much detail about these assessments, but I want to share the assessments that we typically utilize. Each assessment here assesses specific cognitive linguistic areas in a specific way. Some are more functionally based, while others are more traditionally based. Across the continuum of care, when delivering treatment, there are different approaches to therapy. There's a traditional and non-traditional therapy approach. What's the difference, you might say? Therapy is therapy. Well, there is a difference. Traditional therapy approach is a very structured, drill-based method, typically requiring paper pencil, and it usually takes place in a quiet, structured environment, such as a table, a desk, or a quiet hospital room at bedside. This type of approach can be used in all settings. For example, when targeting auditory comprehension, you engage patient at bedside and you give him 10 2-unit yes/no questions. Then, if correct, you progress to 10 3-unit structured yes/no questions. Another example would be when working with a patient on memory, and you're in a quiet environment, you present the patient with irrelevant sentences and you have them repeat them to you. While a non-traditional treatment approach can involve unstructured activities that are patient-led or therapy integrated into functional or community-based tasks. Another way that non-traditional therapy is involved is doing iPads. There's lots of apps out there that can incorporate a lot of good therapy skills and therapy goals. So looking at an example of a non-traditional therapy method, in comparison to the traditional memory task, that same memory task can be transformed to require a patient to recall functional directions to navigate a store, a unit, or gift shop, versus just having the patient recite irrelevant sentences back to you. Another example is incorporating verbal expression targets when a patient's watching television. When working with behavioral patients who refuse to participate in structured tasks, it requires you as a therapist to integrate and embed your therapy goals into what the patient is doing without them knowing. The use of non-traditional treatment approaches can be applied in all settings. However, personally, I utilize it in the inpatient rehab setting, particularly for behavioral patients, and then I utilize it the most in the subacute setting. In the subacute setting, individuals are more exposed to group activities, outings, and events where therapy can be applied functionally outside a structured setting. In daily practice, I have taken patients to the community garden to target sequencing when planting, or work on functional motor speech strategies when communicating during residence council. For my occupational therapist, a non-traditional treatment involves taking apart a wheelchair and then reassembling it. This patient was very handy, but refused to complete structured tasks due to his behavior. For my physical therapist, this might look like having a patient do yoga or ambulate performing leg kicks in a subacute fashion show when the patient walks the runway. However, keep in mind the type of treatment approaches utilized can vary. Within each different setting, there is of course constraints about what resources are available. But for me, I try and think of how creative I can be to tailor therapy to an individual's functional goals and interests, but also maintaining my goals and purpose at the same time. According to McDonald's 2017 study, communication interventions have demonstrated to ease communication distress and increase individuals' overall well-being. This has led to decreased indications of post-traumatic stress, depression, and anxiety. Here are some evidence-based language treatment approaches that can be utilized with this population when there's a language impairment. I'm going to go over some of them listed here briefly. Semantic feature analysis involves the production of semantic information in order to assist with word retrieval skills. An additional treatment method that targets word retrieval is VNEST, verb network strengthening treatment approach. Another approach we have is melodic intonation therapy. This involves incorporating melodic and rhythmic components to assist with verbal initiation and recovery. When we get into the continuum of care, I'm going to link back to these, so please keep these in mind. Then we have the Schul stimulation approach, which involves intense auditory stimulation, all eliciting a response. Moving on from language treatments, here are a variety of evidence-based treatment methods targeting cognitive skills. One technique I frequently use is errorless learning. This can be applied to all disciplines and treatment areas across the continuum of care. This technique is performed by providing cueing to minimize errors with gradual fading of cues as the accuracy of the skill increases. This is in comparison to the trial and error learning approach, which requires self-insight and monitoring. Within this type of population, due to the impairments in insight and awareness, the trial and error approach is not always the most effective. The errorless learning technique is beneficial when done in conjunction with perception measures, which we'll get into a little bit later in the presentation. An additional treatment technique includes prompt, which targets memory training by increasing time delay after exhibiting success. For example, requiring a patient to state different animals every 5 minutes, and after each response, the time frame is increased by 5 minutes. Or it can be applied to a more functional task, my favorite personally, is engaging a patient in a game and requiring the patient to recite the instructions or details following X amount of minutes. Dependent on the patient's level of function, this technique can be utilized in all settings. However, primarily in the inpatient and the subacute setting. Next, I have attention processing training. This technique can be utilized in the inpatient or subacute setting, keeping in mind a patient's cognitive abilities, of course. This technique is designed to improve an individual's ability to focus on information while ignoring distractions. Some ways this can be incorporated into therapy are by playing music during a traditional paper pencil task, increasing the TV volume while completing a paper pencil task, or in a non-traditional route of conducting therapy in a noisy environment such as a hospital lobby. I also have here external aids listed. We're going to discuss that in the next slide. But lastly, the treatment technique I want to discuss is training task-specific routines. This treatment approach focuses on goal-directed practice of functional tasks instead of focusing on the impairment reduction exercises. For example, this might look like in therapy, performing activity of daily living specific to a shower or self-grooming with occupational therapy. And with speech therapy, this might look like a patient operating a cash register in a gift shop to stimulate what they were doing occupationally prior to this injury. This therapy technique can be utilized in all treatment settings. They're effective in assisting with memory, attention, and executive functioning skills. For example, an external calendar can be utilized in order to increase recall of orientation of information, sustained attention, or attention to detail. Lists and charts can be utilized as well. Another type of external aid is a memory book, which involves 3 steps. There's acquisition, referring to a therapist creating a memory book for the patient and familiarizing the patient with it. But you have to keep in mind, if you're utilizing a memory book, it is because the patient has memory impairments. Therefore, it will probably take a couple of sessions for the patients to remember it or get accustomed to utilizing it. Step 2 is application. This is where the patient or staff refers to a patient's memory book and refers to it in order to recall information. During this process, a therapy team approach is so important. With a team support, an individual can increase the carryover across all modalities throughout their day. Lastly, there's step 3, adaptation. This is the implementation of the use of the memory book into the naturalistic setting, where a patient can independently utilize it in their normal day-to-day events in order to increase their memory and their recall. Within this population, there can be a variety of barriers. Brain injury alone can exhibit such barriers. However, due to the history of drug use, there's a new barrier or challenge involved, and that's the challenges of addiction. Before we get into addiction, let's talk about insight and awareness. When I mention insight and awareness, what does that mean? What am I referring to? I'm referring to the patient's ability to be aware of why they're here, whether it be in the hospital, the subacute rehab, or inpatient rehab. Are they aware of their language, cognitive, or physical deficits? Are they aware that they can't stand out of their wheelchair because they're impaired and they might fall to the ground? As I mentioned earlier, damage to the frontal lobe plays a significant role in this area. This is considered a barrier because if an individual doesn't think or notice that something's wrong, why bother to try and fix it? So they might say, why do therapy essentially? Overall, poor insight can lead to decreased safety. We're going to dive a little bit deeper in the area of awareness in the next few slides. So now let's go back to what I mentioned previously, the challenges of addiction. Unfortunately, this barrier does complicate the recovery of brain injury itself due to the underlying mental and behavioral health problems. Because not only are individuals battling understanding that they sustained a brain injury, but also they have to come to a realization that they have a substance abuse disorder or that they've even overdosed. This might include denial, anger, frustration, increased emotions, and confusion. According to Graham and Cardone's 2008 study, limited research in the area of the treatment for substance abuse and the presence of brain injury is out there. However, the general consensus is that a multidisciplinary team that is community-based, offering a variety of different treatment modalities is optimal. Skill-based interventions and peer-based support systems appear most beneficial as well. In addition, when involving a history of addiction in conjunction with a brain injury, there are key aspects that need to be considered when evaluating an individual's discharge plan. For example, if an individual presents with decreased comprehension or ability to express themselves, and they're admitted or transferred to an inpatient drug rehab program, how are they going to be able to express themselves to convey what they're going through? Or how will they comprehend the activity of how will they comprehend the activity instructions required for the inpatient drug rehab programs? If a patient has cognitive impairments such as memory, reasoning, problem solving, insight, and awareness, how would they recall their daily strategies or reason why they're in or need drug rehab? This is why it's so important to make sure that a patient is ready from a language as well as a cognitive perspective prior to being involved in a structured drug program in order for it to be the most beneficial. Although it is up to the individual to stay clean, our goal is to try and set them up with the tools needed to succeed, as well as evaluate when it is appropriate from a language and a cognitive perspective. Insight and awareness. You might be thinking, wow, I've mentioned this a lot lately, but that is because it is very, very important, not only for the hypoxic ischemic brain injury, but also against the battle of addiction. Within awareness, there's a variety of different types of awareness. There's anticipatory awareness, meaning that a patient is able to anticipate when an impairment will affect their performance and require the use of compensatory strategies. Then there's emergent awareness, which is when a patient recognizes when an impairment affects their ability to complete an action in the moment of it happening. And lastly, there's intellectual awareness, which is that a patient might be aware that they have deficits, but they're unable to notice it or identify it. So now that we've just defined and discussed what awareness is, how do we measure it and when do we measure it? Awareness can be and should be assessed frequently across the continuum of care. It can be done by verbally asking a patient, what are you having difficulty with? Or have you noticed any changes such as thinking, walking since admission? Keep in mind, typically the answer is no, and I'm fine, but to formally measure awareness, accuracy perception measures can be utilized, which compares patients' predicted performance versus their actual performance. And another assessment measure is a patient competency rating assessment. This assessment targets higher level functioning skills, for example, an individual's ability to do laundry, make meals, and it compares the patient's reported function to how they score on a professional's evaluation. And lastly, there's the change of assessment scale, the Eureka. This assessment is completed by the patient and it measures the stages of change targeting a specific problem. In this case, drug use. These type of formal awareness assessments would most likely be used in an inpatient rehab or a subacute setting, pending the patient's level of functioning. The key thing to remember when administering these types of tasks or assessment is the type of patient that you're working with. Is this patient overly emotional? Do they get agitated? Are they hypersensitive? These are all things that you want to consider while maintaining a good rapport with your patient. According to Overdose, 2019 study, it was found that there's a significant correlation of functional outcomes in conjunction to an increase in an individual's self-awareness. Looking at the scatter plot here, you can see that as the level of self-awareness increases, so does the degree of improvement. Treatment targeting improving awareness can include test, retest, personal reflection, the use of black and white concrete activities. This is so important because with black and white activities, answers can be either marked right or wrong with no room for subjective interpretation. Sometimes with this population, you might find they'll try and convince you of why they're right or convince you. So it's really important to have things that are very concrete, that have strict yes or no answers, or things that can be marked right or wrong. So far during this presentation, you might have noticed that I'm referring to the different settings across the continuum of care, specific to acute care, inpatient, and subacute rehab settings. Now that we discussed how hypoxic ischemic brain injury can occur and the effects or potential impairments, let's take a journey through the different settings to see how a patient might present, evolve, and how therapy is integrated. According to Solberry and Mader's 2001 study, they found that there's a strong and complex correlation with the frequency and amount of intervention in relation to recovery. This is due to neuroplasticity, which is the brain's ability to change in response to injury and develop new neurological networks to regain function. This is a key component for therapy. Within the acute care setting, an individual's injury is typically very recent or fresh, you might say. When medically appropriate, initial evaluations are conducted by each discipline. After initial evaluations, patients are approximately seen every 2 to 7 days, with a duration of sessions going from 15 to 60 minutes per treatment session. Keep in mind, each patient is and can be affected differently dependent on the severity of the injury. However, some clinical presentations that you might see at this level are poor arousal, delayed processing of auditory information, increased spasticity and tone, decreased ability to speak, confusion, dysphagia, and evidence of substance withdrawal such as shaking, sweating, vomiting, and pain. Typically within this setting, when treatment is delivered, it is delivered in a more traditional treatment at bedside. Within the inpatient rehab setting, an individual is more medically stable compared to their acute care stay, and is further away from the date of onset. In this setting, reevaluations are connected because typically there are changes since the initial evaluations conducted on the acute care service. Assessments utilized by all disciplines are typically standardized and treatment is administered 5 times a week. This is where the correlation of treatment and intensity and neuroplasticity is so important. Like I said before, keep in mind each patient is and can be affected differently dependent on the severity of the injury. Within this setting, some clinical presentations that you might see are improving arousal, auditory processing, and verbal expression, orientation, and here you'll start to see the emergence of notable cognitive deficits. Also another thing is a varying presentation of tone, such as an increase in tone or decreased tone can be seen. Typically here as well, a patient will begin to gain more function and more strength, but also will begin to exhibit new barriers, such as described previously, such as increased impulsivity, decreased insight and awareness, and poor safety awareness. Typically within this setting, treatment can be performed via traditional or non-traditional treatment approaches. Within the subacute setting, patients are living and operating in more of a community-based setting versus staying in their individual hospital room for the duration of their stay. This type of setting typically presents patients with options to complete activities or events within the facility. In regard to therapy, upon admission, patients reevaluated again, and the patient receives therapy 2 to 5 times a week, ranging from 30 to 60-minute sessions. In a subacute rehab, patients typically continue to exhibit improvements in varying categories. Some patients make improvements faster than others. However, it is really dependent on the patient and their rate of recovery. Within this setting, both traditional and non-traditional treatment approaches can be utilized. Personally, I find that I use non-traditional treatment approaches the most in this setting. As I mentioned before, some might look like patient doing their laundry, cooking a meal, participating in residence council, setting up facilities gardens, or it even can take place during community reentry programs such as navigating Target, buying pizza, or cashing a check at the bank. At this level of care, you're preparing the individual for the next step. This could be home, a residential community, or long-term care. Therefore, making therapy as functional as possible is very important. I'm now going to get into a case study of one of my previous patients who I was able to evaluate and follow across the continuum of care. We're going to analyze his presentation as well as his evolution of his rehab journey across the continuum of care. This patient was a 24-year-old male with a past medical history of bipolar disorder, asthma, and heroin abuse. He was found unresponsive and bleeding. Narcan was administered in the field with little effect. Upon admission, the patient was intubated and mechanically ventilated. He was in acute renal failure, febrile, and hypotensive. The initial diagnosis of septic shock and anoxic encephalopathy was made. He exhibited stiffness in all of his extremities, and MD reported spasticity could be a result from a hypoxic or hypercapnic brain injury. A psychiatric consult indicated a possible intentional suicide attempt. Patient was extubated the next day and noted to be tremulous and agitated. The patient exhibited intermittent diaphoresis and was suspected of an opiate withdrawal. When reviewing this patient's neuroimaging, his CAT scan of his head without contrast exhibited no evidence of acute intracranial hemorrhage, vasogenic edema, mass effect, or extraaxial collection. Sulci and ventricles are normal in size and configuration. His MRI revealed prominent confluent white matter signal changes, and his EEG revealed generalized slowing of the background, but no seizure activity. So, if the CAT scan of his head without contrast exhibited no evidence of acute intracranial hemorrhage, etc., so why does he have therapy orders? This is a key example of what Dr. Greenwald mentioned before in the previous slide, that according to Hong et al.'s 2019 study, imaging does not always consistently correlate with the clinical presentation. And this was the case for this patient. Upon entering the room to evaluate this patient, he had significant tone in all of his extremities, dysphagia, physical impairments, language deficits, and more. So looking a little deeper into this patient's social history, he completed 1 year of college education. He was currently employed full-time in construction. He was living at home with his parents and younger siblings, including a younger sibling with autism. Here, it was reported that he utilized alcohol socially. His family reported a history of use of cannabis, Xanax, and cocaine use, as well as the use of heroin intranasally 4 to 5 times a week for the past 3 years. According to the patient and his parents, 9 months prior to his overdose, he had been in a 3-week inpatient drug rehab program. At the time of his overdose, his parents were distraught because they had thought he had been clean since completing the drug inpatient rehab program. His family was unaware that he was using heroin again. Over the next few slides, I've compiled a variety of data from this patient's assessments across the continuum of care. In a few slides, we're going to analyze the patient's rehabilitation across the continuum of care side by side. But jumping into the acute care setting where I first met this patient in the ICU at bedside, 5 days status post-overdose. The patient had difficulty opening his eyes, decreased and delayed responses to auditory information, low vocal quality, confusion, significantly increased tone. He was unable to move his arms or legs, and he was actively going through withdrawal as exhibited by increased shaking and sweating. As you can see in the chart, I conducted formal assessments. The patient was placed on a modified diet of puree solids with honey thick liquids, exhibited moderate receptive and expressive impairments, and severe cognitive impairments. Regarding mobility, he presented with severe impairments as exhibited by patient was dependent for rolling, transfers, sitting, and dressing. As I mentioned in previous slides, treatment in this setting does not occur frequently or potentially as long in comparison to the other settings. Treatment typically is conducted at bedside, utilizing traditional style of treatment approaches. After leaving the acute care setting, the patient was transferred to inpatient rehab. Following admission, the patient's diet was soon upgraded to dental soft solids with honey thick liquids. Comparable to his initial evaluation, he continues to exhibit moderate motor speech, receptive, expressive language deficits, and severe cognitive impairments. However, in comparison to the acute care evaluation, we're starting to see the progress over the course of his recovery. The patient's exhibiting an improvement in insight and awareness, attention, and his mobility. Now a patient is currently at a moderate level with physical therapy, performing modified stand pivot transfers. However, continues to exhibit decreased motor planning, which negatively impacts his performance and abilities physically. In occupational therapy, the patient's currently max assist for toilet transfers and hygiene, max assist for lower body dressing, and min assist for upper body dressing. Within this setting, traditional and non-traditional treatment approaches are and can be targeted. For example, when targeting auditory comprehension, I utilized the traditional Schul's stimulation approach, which was utilized to target increasing the patient's auditory comprehension and verbal fluency. In addition, in order to increase the patient's word finding abilities, I utilized the semantic feature analysis treatment technique. When targeting insight and awareness, black and white treatment activities and self-perception measures were the most effective. However, at this level of care, despite the use of perception measures, the patient continued to exhibit poor insight and awareness. Regarding his behavioral and mental health, at this time, he was continuing to exhibit denial, inferior complex, poor judgment, and insight and awareness. During his stay in inpatient rehab, the patient was consulted by behavioral health, psychology, and neuropsychology. He was discharged to a subacute rehab setting following inpatient rehab in order to increase his physical, cognitive, and language abilities. Some might say, why was this patient discharged to subacute and not straight to inpatient drug rehab? Due to the type of a hypoxic ischemic brain injury as a result of an opioid overdose and his current levels of deficits, inpatient drug rehab wasn't appropriate at the time, or would it be effective due to these levels of language and cognitive impairments. After inpatient rehab, he was admitted to subacute rehab. Here you can see he's made significant progress in multiple areas over the course of his stay at inpatient rehab. Upon evaluation, he was upgraded to a regular diet, exhibiting mild language deficits, mild orientation, and mild cognitive impairments. In occupational and physical therapy, he had progressed to mild level deficits. These are huge improvements. However, our journey of recovery is not over just yet. Within this setting, both traditional and non-traditional treatment approaches were utilized. For example, some non-traditional treatment approaches included ordering food and navigating unfamiliar places based on memory, but also developing goals for the patient himself. During this stay at subacute rehab, the patient's insight and awareness to his cognitive deficits, as well as his addiction, improved. At the times, he exhibited increased emotions such as anger and frustration. When exhibiting these emotions, he was referred to counselors and behavioral health. However, then when consulted, the patient would just shut down and not engage. This is where the team approach became so important. Yes, we are therapists. However, due to the extensive time spent with the patient, we've developed significant rapport with the patient for him to feel comfortable and open up. Then, as professionals, we consulted with behavioral health to provide us with recommendations on how to provide the patient with the additional support that he needed at this time, when not only battling his cognitive and physical deficits, but also with his battle of addiction. Over the course of his therapy, we utilized self-perception measures such as self-rating scales, diagrams, and the Eureka assessment to work on the patient's self-reflection and understanding on how his body was functioning, but also to assist the patient with understanding his own addiction. Over the course of his stay, we began to notice an increase in his understanding of the situation, as well as reflecting on it. For example, during the discussion of his overdose, the patient told me, "Looking back at it, I remember the lady who sold it to me. She said that you are too young and this is too strong and to be careful." But the patient said, "I didn't care. I was strong and I would be fine. But looking back at it, I was really just stupid. I just wanted a fix." Here I wanted to include this because I found it really interesting. Here we have an image from the patient's initial evaluation from the subacute rehab setting. You can see here this task, usually you instruct him to draw a clock, including all of the numbers and times, and set the time to 10 past 11. Here you can see his poor thought organization, attention to detail, even had some neglect and inattention going on. As you can see here, I have the data from the patient's subacute discharge. I'm going to skip over this slide so you can see it in comparison to the previous reviewed levels of care. After discussing the patient's clinical presentation, interventions, and progress at each level, I wanted to compare them side by side. Here you can see the evolution of the patient's recovery across the continuum of care. You can see looking from his level of impairment in the acute care to discharge from subacute rehab, he really has made amazing progress and improvements. He went from being bedbound on admission to walking out of a subacute with a family. It is important to keep in mind within this population, despite this case here of an amazing recovery, some individuals are not so fortunate. So now what? Following discharge from our subacute rehab program, this patient was admitted to a dual diagnosis outpatient program. But for this type of population, other options for discharge can include outpatient therapy, residential program, long-term care, home, or sometimes home. Dual diagnosis programs, specifically for the hypoxic ischemic brain injury population with a history of addiction, there are some options such as dual diagnosis programs. However, unfortunately, dual diagnosis programs are extremely limited. These programs provide resources for traumatic brain injury and substance abuse disorders. Programs can include, but are not limited to, detoxification, individual therapy, group therapy, addiction counseling, 12-step programs, and relapse prevention programs. Like I've mentioned previously, it is empirical that an individual is enrolled when their abilities are at the level at which a patient can benefit the most, as well as be able to retain it. Where is this patient now? Currently, this patient is 1 year and 6 months clean. He graduated from a halfway house and is currently living independently. He's employed full-time and he has started a family. Here are some of the disciplines that I work with and are involved with on a daily basis. I'm going to close with this slide, but when working with the hypoxic ischemic brain injury population due to opioid overdose it really takes a multidisciplinary team approach across all settings. Across all settings, all of these disciplines are important in order to suit the needs of the patient, as well as in order to provide the patient with the best care. I wanted to say thank you so much for joining me today and learning about the hypoxic ischemic brain injury due to opioid overdose. If you have any questions at this time.
We have a couple questions that came in. The first was, how can typical recovery programs need to be adapted to an individual with a TBI?
Sorry, can you repeat it one more time?
Sure. How can typical recovery programs need to be adapted to an individual with a TBI? I guess maybe the question's instead of an ABI.
So for this, so typically within this population, I'll be honest, I use similar approaches that I utilize with with the acquired brain injury as well as a TBI. They do overlap a bit. The big difference is the addiction piece. But overall, I utilize the same kind of treatment approaches, but also tailor them individually.
Okay, and then we have one more question. Someone asked if you how you get the family involved in treatment. I think you talked about this a little bit. This was an earlier question, but she was curious. She said, when my brother was being treated for aphasia, his speech therapist created a binder for me with flashcards. I didn't know if this was common.
For our patients, it's very common. We are very involved in patients' families and really operate on more of a fluid approach by providing them with compensatory strategies, such as how to increase their ability to communicate via understanding, use of written communication versus verbal communication, but also we do make packets in order to help families understand, but also in order to do not therapy, but also involve the patient and in order for them to communicate effectively with their family, to make them involved, because I'm on the phone every day or every other day calling families to give updates, but also to give them strategies on how they can connect with their families to make it meaningful, but also, to feel involved, because it is a very emotional and it's a very hard time that families are going through over the course of the journey through all settings. So I really try and provide families with the opportunities where they see their, or I'll have them come in and do some family observation with me during therapy, so they can see how I'm targeting certain skills, but also so they can kind of see the improvement, especially for lower level patients who, for instance, they aren't verbally initiating things yet. They can't really say anything, but they're either doing things with their eyes or they're pointing. For instance, yesterday I had a patient who had history of opioid use, and I was telling the mother, the patient can't verbalize, but I was showing her how she could name objects with a choice of written cues. And her mind was blown because she was unaware that her daughter, the skills that her daughter had, she wasn't just, laying in the bed, not being able to communicate, but she really could communicate. This is also when the use of AAC boards come into play, and just instructing and educating families on how to use these kind of devices in order to communicate and have those interactions with their family members.
Thank you. We have another question. Jennifer B says, I work with a severely aphasic patient who did well with language and socialization gains, then regressed. What are potential reasons for regression?
So I don't know the full case of the story of the patient, but what I would see, I'm curious to see what kind of setting they, after, seeing the patient, were they going to a setting that they weren't exposed to a lot of communication, or were they not exposed to continue, I think about the use it or the lose it, if they make all these gains, if they don't continue to utilize the skills that they've learned or completed, are they not using that? Are they living alone and not communicating as much? But the reason for regression, I'm not sure, if there's a medical change, but I think that the key thing is when utilizing and learning these new techniques is to continue to apply them to a functional daily life and utilize them daily.
Okay, we have another question in the chat. How are patients treated for withdrawal during this time?
So I'm going to leave that one up to Dr. Greenwald because that's more of a medically based question in terms of how they're going through withdrawal. From a speech point of view, when patients are going through withdrawal, what I do is I try and kind of look at their behavior, provide them encouragement. Like it depends at what level, for instance, when this patient was going through withdrawal, he really wasn't communicating much. He was, shaking and sweating. And I really refer to the team approach here and have nursing come in and help me because unfortunately, some of the things that I can't manage, but if, they're going through active withdrawal, such as yelling and behavioral, then I kind of look for signs that they're, I kind of try and get them at the best time, such as if they're, if they're coming down off of a fever or, just kind of looking at their body mechanics.
Yeah, I think Tara, those are good points. We need to really, when we do sometimes have patients who come into us who are still in the active phases of withdrawal, we use pharmacology to sort of slowly bring them off of the opiates or slowly bring them off of benzodiazepines or slowly bring them off of alcohol. We're lucky over at JFK, we have a great pharmacy staff also who's very helpful when it comes to these type of issues. Sometimes we'll have psychiatry involved also. But the idea is to try to find that balance between maximizing their awareness and arousal, since many of these medications to help sort of slowly withdraw them are sedatives, and yet for them not to go through a full-blown withdrawal, which certainly can be life-threatening. So it's certainly important to be thinking about in these patients and to be carefully monitoring and treating. With regards to that last question, I'm sorry I didn't have a chance to jump in, but as far as someone who's made a regression, I think you certainly have to think about the medical issues also. I think the points that Tara brought up were really important, but thinking about the medical issues also, could there be new seizures that are going on? Could there be new infectious issues that are going, could there be going new, new metabolic issues that are going on? And I know myself as a rehabilitation physician, I'm very sensitive to the therapist coming up to me and saying that the person seems like they're not doing as well. Sensitive in the sense that I know the therapists are the ones really on the front lines, seeing the patients so many more hours than I am in a given day. And so when they say something like that to me, I want to look and see if there's some sort of new medical issues going on again, new neurologic issues, metabolic issues, infectious issues, hormonal issues. And it takes a trained eye to look at those things to be able to thinking about those things. But again, recognizing the importance of the frontline therapists and nursing staff and the importance of their insight into such patients.
Thank you. If anyone has any other questions, you can put them in the chat while I just do some housekeeping things. We ended a few minutes early. Our exhibit time is from 11:20 to 11:50, and then the afternoon workshop starts at 11:55. So in the chat, I've put in the link to do the different evaluations. Please make sure you do those throughout the day, especially if you're applying for CEUs. And I also put in a link to attend the various exhibitors also. So it looks like there's no more questions. So I just want to thank you again for being here and participating in our seminar. And we will see you in a little bit.